What I want to know about plaque is, I think, to simplify it into the A, B, and C of plaque characterization. A for architecture, which you can get from IVUS and also to an extent from OCT, which we'll talk about. B, biology, which I would include coronary flow, because you want to know if it's flow limiting. And C is composition. We've already talked a little bit about the importance of architecture, of knowing the volume of the plaque and the minimal lumen area, etc. Also eccentricity and positive remodeling, which we'll talk about in the context of vulnerable plaque. But what the question you've asked really gets to is the whole concept of vulnerable plaques and what a vulnerable plaque is. And so let me turn the tables for a second and flip it back to you. You would be rightly considered the father of vulnerable plaque in terms of the seminal studies that brought the concept into the field, that there were these lesions out there that were responsible for myocardial infarctions and sudden death that were not clinically overt until they produced these calamitous events. You've spent quite a bit of time thinking about this problem and now developing technologies to try to elucidate how we can detect it clinically. Tell me how you think about vulnerable plaque and how it started and where we're at in clinically in taking those concepts and now measuring vulnerable plaque and maybe making a difference for patients.
I came at this field, as you know, through the coronary care unit. Saw these patients in front of me. They had heart attacks, and I had found that their heart attacks are more frequent in the morning than other times of day, and we published that. And then we started looking at other triggers like anger, heavy exertion, and we published all of that. Then I began to think about the disease, and I was wondering, why would it be quiescent one day and suddenly the plaque ruptures, causes a clot, causes a calamity? And I thought maybe the good term for these plaques would be vulnerable plaques. So we published that in '89, and basically since then we've been trying to find vulnerable plaques. I think the lipid core plaque with the thin cap and the macrophages that sounds scary is probably a vulnerable plaque. But we don't quite have all the data we need yet to prove that. It's indicted, but not yet completely convicted. So I think that what we've tried to do is build the right instrument to find lipid core plaques, and that turned out to be spectroscopy. It's successful. It's FDA approved for lipid core. It's very good at it. And now what we're finding, and as you know, we're collecting more and more cases for long-term outcomes, is that if people have a lipid core plaque, it seems to imply more trouble in the future. We expect to nail that down a little more tightly with some studies in progress.
Because you hear these terms, vulnerable plaque, and is that a histologic definition or is that a clinical definition? Then you hear TICFA, and you hear complex plaque. Could you just simply check off the features if we were looking at a post office wanted poster for what that rogue plaque looked like? What is a TICFA and what is a vulnerable plaque, and what do they look like, and then what instruments do we have available to measure those things?
So the vulnerable plaque concept is that it's a plaque that's likely to rupture and get a clot. You can imagine a more clinical definition, which is a vulnerable plaque is one likely to cause an event. So those are related. And then you go from those concepts down to the real world, to histology, and you look and you see what do these plaques look like that have caused events. Look backwards. And you see that they have a big lipid core, and they have a thin cap, and macrophages, and collagen that's weakened. And these are called thin-capped fibroathromas, TICFAs. And those TICFAs, most people think that they are indeed vulnerable plaques. They're suspected vulnerable plaques. It's been hard to prove they are because it was hard to measure them ahead of time. Now, there's been some marvelous progress with the Prospect trial. You know that quite well. I think 697 patients, they all got measured with grayscale IVUS and with VH and followed for 3.4 years. And that study actually found vulnerable plaques. It found plaques with certain features that were much more likely to cause events. So I think that study was a real success. The features were grayscale IVUS, plaque burden greater than 70%, minimal lumen area less than 4 millimeters squared. These were very strong predictors. VH also predicted, but most of the prediction, in my sense, reading of the papers, was done by the grayscale IVUS. Then you can ask, well, if Prospect has done this, why aren't we screening the country for vulnerable plaque, treating them and getting rid of this 1 million heart attacks a year? And the answer is, one, it's an invasive measure, and two, the relative risk was not that high, and the finding was not specific enough. So we believe that with better detection of lipid, you would be able to find higher relative risk, more specific prediction.